Hi, I'm Michelle. I'm here today to present RT, who's a 56-year-old African American male who presents today at clinic with increasing complaints of depression and COPD. History of present illness: the patient states that he suffers from a terrible depression since his heart attack 3 years ago and has exhibited a depressed mood consistently for the past 6 months. He stated that he does not have any interest in his hobbies and has a constant feeling of guilt, fatigue, and worthlessness. He feels less inclined to spend time with his friends and has troubles recently with abilities to concentrate at work. RT states that this season is particularly difficult for his depression, with the colder weather, holidays, and spending his birthday alone contributing to his overall feelings of worthlessness. RT stated his attempted treatment with citalopram prescribed by cardiology 3 years ago. It worked well for improving his symptoms, but RT complained that it caused erectile dysfunction and diarrhea. Today he is actively seeking treatment for his depression and would like to pursue drug therapy again, but with something that doesn't cause these side effects. RT wants to turn around control of his life. He states that he can control his depression. He would be willing to attempt to quit smoking. And if he can just breathe a little better, he may even start an exercise regimen. He would love to be able to exercise again and lose some of his excess weight. He does not exhibit any signs of bronchitis with his COPD, but he does have symptoms of shortness of breath while walking and during exercise, but not extensively with rest, which has limited his ability to exercise again. His past medical history is depression, ST elevation, myocardial infarct, hyperlipidemia, and COPD. His pertinent family history is positive for depression in his father, who died at age 62. Nothing pertinent with his siblings. Pertinent social history: he's an IT specialist who was married. His wife passed away 1 year ago. He currently smokes tobacco, 1 pack a day. Alcohol use is occasional, more than the past weeks within normal with the holidays. Illicit drugs are none, exercise is none, and diet includes increased calorie intake within the last 3 months. He has a 15-pound weight gain in the last 6 months. Drug allergies are adhesives. Creatinine clearance is 162, EGFR is 97 today. Medications are metoprolol succinate, 50 milligrams daily, fluticasone, 100 milligrams, 1 puff inhalation by BID, albuterol MDI, 2 puffs Q4 hours PRN, shortness of breath, atorvastatin 80 milligrams daily, and aspirin 325 milligrams daily. Vaccines were 2022, PPSV 23, and influenza. High priority problems today are acute MDD and COPD, which started in 10/3/16. Low priority are ST elevation, myocardial infarct, which happened on 1/15/20, and hyperlipidemia. RT is currently expressing major depressive disorder. This is based on the HAM-D score of 16, and he's also exhibiting signs of increased depression throughout his initial exam today. He does not have any interest in hobbies and has constant feelings of guilt, fatigue, and worthlessness. He feels less inclined to spend time with friends and has troubles concentrating at work. Patient was seen by our second-year medical resident, Dr. Patel, who reports that RT is a severely depressed male with an extensive cardiac and pulmonary history. Based on these symptoms, I would place him in an acute phase of MDD. He is currently not on any medications for major depressive disorder. He has tried Celexa in the past, but experienced side effects such as diarrhea and erectile dysfunction. Dr. Padma is considering restarting Celexa 40 milligrams PO today. My recommendations are to discontinue the Celexa based on the side effects and begin duloxetine 30 milligrams daily. Rationale: per 2024 APA recommendations for adults with acute MDD, supports the selection of a second-generation antidepressant because of the reduced rate of side effects. This medication will not cause the undesired side effects of diarrhea. However, it can cause erectile dysfunction, though not as often as Celexa. Recommendation 2 is to begin a cognitive behavioral therapy, and problem-solving therapy. Rationale is APA 2024 recommendations. It is also considered a conditional recommendation for adults with medical and other complications such as COPD in RT's case. Recommendation number 3 is initiate bupropion XL, 150 milligrams. Bupropion has no effect on the 5-HT reuptake, but inhibits both norepinephrine and dopamine reuptake. Counseling would include that this is one of the most activating antidepressants that have been approved for depression. It is helpful for increasing motivation for someone who is low energy and fatigued, such as RT. It also is approved for smoking cessation. It is approved for associated with less sexual side effects and is often prescribed along with SSRIs to improve their sexual dysfunction-related side effects. One other major side effects include nausea and vomiting, tremor, and dry mouth. Rationale per 2024 APA guidelines, it's recommended that patients who have failed on one second-generation SSRI or have failed due to side effects and should be tried on another. Moving on to COPD. According to his CAT score, RT has a high-level uncontrolled COPD. His COPD diagnosis is confirmed by the results of his FEV1 over FVC being less than 0.7. I took the time to grade his symptoms using the results of the FEV1 was 60%. This places him in a gold group of moderate. His FEV1 over FVC equals 60%, while we like to see results greater than 0.7 to be considered good. His score places him in the gold group of B. Because his history was like it has been without exacerbation leading to hospitalization within the past year, and because his CAT score done separately was 21, which is greater than or equal to 10, this places him in the gold subgroup 2B, which is used to determine treatment. Currently, therapy for COPD is fluticasone 100 micrograms by inhaler BID. This is inappropriate based on his eosinophil counts. Inhaled steroids should be reserved for those with eosinophil counts greater than 100 per 2025 Gold Pocket Guide. So my therapeutic plan would be to discontinue the fluticasone because it's not appropriate for his stage of COPD. Start a LABA plus a LAMA such as a noroellipta, 1 puff daily. Rationale, single inhaler therapy may be more convenient and effective than multiple inhalers and increase compliance. Number 3, continue albuterol MDI, 1 puff every 4 to 6 hours as needed for management of exacerbations. Number 4, update vaccines to include COVID, shingles, and RSV. Number 5, increase physical activity as ad lib to a goal of 150 minimum minutes per week per ACCA-HHA guidelines. Rationale, physical therapy or physical activity is a strong predictor of mortality, so all people with COPD should be encouraged to increase their physical activity. And number 6, smoking cessation and add a nicotine patch at 14 milligrams daily along with nicotine lozenges, 2 milligrams every 2 hours as needed for cravings. This will assist along with family support in increasing his chance in success. The bupropion will help as well. Patients should follow up in clinic in 4 to 6 weeks for a med check. 9 minutes. I can't get it under 9 minutes.